Big thumbs up. All right, so with that big thumbs up from Ani, again, I'm going to welcome each and every one of you to this evening's AMCSI virtual event. Again, we're going to get started with a presentation in just a moment, and I'll turn it over to Ani to cover that presentation. But before I do that, as a technical moderator, it's my job to cover a few basic housekeeping items to make sure that everyone understands how to participate. So our session today will be hosted live in Zoom, and you'll be able to join on any device with internet, or you can simply call in on the phone lines if you like. Everyone will be muted, and we ask that you stay muted to minimize any background noises. We'll explain how you can come off of mute later on today as time permits, but until then, we will keep you on mute. We will also ask that everybody be respectful since this is a family-friendly event, and for some of those reasons, we'll be focusing our cameras on our invited speakers, and we've set the meeting chat to be directed straight to me, the meeting host. So you can open up that meeting chat and send in questions, comments, or report technical issues at any time by sending a message to me directly as the technical moderator. To make sure that you're all comfortable with that, go ahead and open it up right now, because you know what I love when I'm running a webinar? I love getting greetings. So if everybody could send me in a little hello or hi in that meeting chat, I would love to see those messages. That will also help me be sure that you guys are actually listening and you are ready to get started with our virtual session today. Oh, look at these greetings. Oh, you are making my heart happy. Thank you, ladies and gentlemen. Thank you. All right, and our session today is being recorded. So AMCSI will post this recording so that you can access it later on and watch on demand. So we'll follow up with you later on so that you can access this through the AMCSI website. All right, very quickly, I bet you've been in a Zoom meeting before in the past year or so I won't go through all of the controls in great detail. But remember, for those of you on a computer, you should see controls in the lower left to change your audio connections. You'll see a portion of your screen where you can follow along with our presentation materials. And then there will also be additional controls where you can look at who's joining us, open up the meeting chat, and then also send in those comments and private questions through the meeting chat. You can see who's speaking and then change the view as well. If you are participating on a mobile device, and it does depend on the type of mobile device, Androids and Apple devices sometimes have different controls. You'll see things a little bit differently, but as you swipe to the left or the right, or you look for the 3 dots or more options button, you'll tend to see some additional controls, which will allow you to open things like the meeting chat, as well as raise your hand or socially respond to our presentation today. All right, we've got many more people joining us today, so we'll click through these. If everybody feels comfortable with Zoom, why don't you go ahead and give me a big thumbs up in Zoom? You all know how to use it. You've been in it all year. I know you know where the social responses are. Look at that participant panel lighting up with my thumbs up. Fabulous, much, much appreciated. Okay. Well, I think you've heard enough from me. I've tied up a little bit of time. I see a couple of hands have raised. If you have a question, I'll come back to you in just a moment. But what I'm going to do is turn it over to the lady of the evening, our session facilitator, and allow me to spotlight her video so that you can all see it. And Ani, why don't you take it away?
Awesome. Thank you so much, Jean. I appreciate all that you do for AMCSI. Behind the scenes, Jean is part of our Loom crew along with Michelle. And so we really do appreciate all your hard work here tonight. Good evening, everyone, and welcome to our AMC Awareness special event. We are so excited to have you here with us tonight. But before we start, I wanted to first give a huge shout out to our behind the scenes. Besides Jean and Michelle, we also have Alex Spitzer and Brandon Vera on our Facebook Live, who will be interacting with our Facebook family. So we're very thankful for all of you for taking the time out of your busy schedules to be here with us for this special event. For those of you who do not know me, my name is Ani Samarjan. I am one of 6 board members of AMCSI. I'm also mom to Abby, who is my oldest and my AMCer. Not many people know this, but 16 years ago, on this very day, June 30th, AMCsupport.org was launched. It was the message board that started all the conversations to move our support group into a real-life setting. Though we have not seen one another in almost 2 years, we are so thankful for our AMC family who is willing to adapt to a new way of community and provide support through our weekly Zoom calls. You all know who you are. And hopefully soon we'll be able to get back together in a real life setting through our mini meetups that will hopefully launch in a city near you. Just for a little bit of background information, you have a good bit of information on your screen right now, but AMCSI is a nonprofit organization that was approved for its 501c3 status in 2007. Since then, we have grown tremendously in numbers and in need. AMC Awareness Day has been celebrated for the last 12 years with our families from all over the world supporting our initiative. Friends, family, our medical professionals, celebrities, and our pets are wearing blue for AMC today. Today also marks one of our biggest fundraising days of the year. To date, with your help, shares, likes, and comments, our friends and family have helped us raise over $50,000 in 30 days. You guys are amazing. Thank you so much. We want to acknowledge some of our fundraisers. Some are annual and some have done just a fundraiser this year alone. Roger's Run for AMC, Stand Ups for a Cause, Run for Jack, Val's AMC Music Festival, the Greenview Hospital and the Woods family, all of that have created a birthday Facebook fundraiser for us, the Big Little School, and of course, Valerie and Will Bolsowitz is one of our AMC families who has graciously donated matching donations for the month of June. All donations raised over AMC Awareness Day will help us fulfill our community give back programs and help fund our medical travel grant, our adoption fund, college scholarship, and provide our medical community researching arthrogryposis. We are so thankful for all of you for making this AMC Awareness Day the best one yet. It is now time to introduce to you one of our friends, Rosa, and her mom, Leslie. Take it away, Rosa.
Okay. Hi, everyone. Hi, Dr. Bambosa, and thank you, Annie, for having us. Happy AMC Awareness Day. My name is Rosa, and this is my mom, Leslie. And as you all know, I am 12 years old, and I was born with arthrogryposis. Take it away, Mom.
Hi, everyone. Thank you so much for having us here. I want to share with you guys my experience with Rosa and Dr. Bambosa. I had Rosa 12 years ago, and when I first had her, I wasn't sure what route to take. I was very confused. I didn't know, but luckily I met Alexis, and she guided me to the right place, which is Shriners Hospital. And that's when I met Dr. Bambosa. For me, I am just so grateful for all that he does for everyone. For the first time I met him, we were talking and he started telling me, yeah, we're going to do this and that, and she's going to walk. And our previous doctors told us that she wasn't going to walk, that she was going to be in a wheelchair, that we were going to accommodate her life and all that. So when I heard Dr. Bambosa saying she's going to walk, I mean, he was just speaking a different language to me that I felt like, yes, I'm at the right place. This is the right time. And from there on, every milestone Rosa kept accomplishing. And eventually she walked out of Shriners. And for me, that's so meaningful. And I'm so thankful for all that you do, Dr. Bambosa, for all the families that you help all around the world. you're so dedicated, and we're just so grateful for you and for this community.
And I would like to add to that, Mom. Thank you so much, Dr. Van Bosse, for doing all of these surgeries to help me in a bunch of different ways. For example, when I had my surgeries, you would help me walk, and you and my mom have basically helped me become the person I am today. And I'll be forever grateful for that.
One last thank you. I also, Dr. Van Bosse, would like to thank your wife for supporting you so much and allowing you to do what you love and be there at all times, and for your family. So thank you so much.
And I'd like to welcome the one, the only, Dr. Harold Van Bosse.
Sorry, I had to get permission to talk there. What a great surprise seeing you guys. Thank you so much for the introduction. And I can only say it's a privilege to treat you. And I think that all of us who treat children with arthrogryposis realize how rewarding it is, and excited to see the advances that we can make with it. But I think that I'm supposed to start talking about my talk. So let me go ahead and share my screen and see if I can make this work. Yeah, this is the technical part that I was not that great at. Share screen, and we're doing this one. And somebody's going to tell me that this is working.
And it is working. Please go ahead.
Super. All right. So first of all, I want to say it's a great pleasure to be invited to give this talk to kick off our meeting season here. And I certainly miss doing this in front of everybody. And in fact, it's a little bit weird doing this to a camera, because when I do it in front of the audience, I can kind of judge how the audience is doing. And here I'm kind of guessing how you guys are all doing. So hopefully you'll all stay awake for the rest of this talk. But let me, whoops, that didn't work. Let me get this going here. So when we talk about arthrogryposis, we oftentimes will start off talking about this painting that hangs in the Louvre. It's about the size of a sheet of notebook paper. It's called the club foot, but we actually think it's one of the earliest depictions of somebody with arthrogryposis. It's got that very characteristic wrist shape and a club foot on the right, maybe a congenital vertical talus on the left. But arthrogryposis itself, what does it mean? Well, the word arthrogryposis breaks down into arthro meaning joint and grip meaning curved. Multiplex just means multiple joints involved, and congenital means it's present at birth. We call it AMC for short. And the working diagnosis is a congenital, meaning that the children are born with it, non-progressive limitation of two or more body parts, usually meaning that the contractures that they have at birth are not going to get worse in any typical way. For example, the opposite of, say, cerebral palsy, where the contractures do get worse over time because there's spasticity. It's a descriptive term, though. It's not really talking about a specific condition. And that's because there's so many different things that can cause a child to have arthrogryposis. But it does give us a term to talk with each other about in terms of describing somebody who's got multiple joint contractures at birth. The overall incidence is about 1 in 3,000 births, but there's more than 400 different things that can cause a child to be born with arthrogryposis. What do all these kids have in common? Well, we think that what causes all this is the fact that they were not moving enough intrauterine, something called fetal akinesia, where kinesia means motion, and you throw an A in it means that there's a lack of motion. In your stages of pregnancy, the first couple of months are the embryologic stage. It's where you get a cell from mom, a cell from dad, you put them together, and over 2 months' time, you build that up into a very miniature looking baby. And then the next 7 months are taking that miniature baby and growing them up in size. And so we think that the things that cause fetal akinesia have their effect during those last 7 months. So the baby's actually put together fairly well, but then they stop moving. And then what happens? Well, you have the joints that become stiff. You need to have motion of the joints in order for them to move correctly once the child is born. So you get fibrosis of the joint, meaning essentially scarring within the joint. Top of that, the muscles get tight, the ligaments get tight, the skin gets tight. And you also will have a lack of skin creases. And my favorite place to look for those skin creases is the back of your hand, where you have the little creases across your knuckles. You got those when you were getting developed inside your mom. And you also get things like this, these skin dimples. This is where the skin got stuck down to the underlying bone because it wasn't moving around very much intrauterally. You can get other abnormalities from not moving around much intrauterally. Fetuses actually swallow and breathe. They practice these motions. So if they're not doing that, they're not swallowing, the gut doesn't form well. And that helps explain why so many of the children with arthrogryposis have constipation. They also aren't breathing in the amniotic fluid the way they should be. So their lung muscles or their chest muscles are not working to the degree they should be. And sometimes the lungs are also underformed. They can have a small jaw because they're not exercising their jaw. Gut motility problems we talked about, lung problems. And there could be something called polyhydramnios, where there's too much amniotic fluid because they're not processing it the way that they should. Also, when the fetus is kind of kicking around inside the uterus, it helps to stretch out the umbilical cord. So when they're not doing it, they can end up with a very short umbilical cord. So how do these 400 different causes of arthrogryposis cause the fetal akinesia? As you probably figured out, there's a lot of different ways to get to arthrogryposis. And in some cases, it can actually be that one cause causes the akinesia in two different ways. But so starting at the top, we're starting with the nervous system. If you think about the nervous system, it is essentially the brain that does the thinking, and then there's cables going down to the muscle. And any point in that operation can have an issue. So you can have the brain being a problem where you have structural abnormalities. So on the right, you have an MRI of a normal brain. On the left, you have a brain that has perisylvian polymicrogyria, which is probably one of the most common causes of brain influenced arthrogryposis. You can also have an absence of the corpus callosum, which is the bridge between the left and the right half of the brain. Coming down further, we can have abnormalities with the spinal cord, and we're going to talk about that in a little bit. Or the nerves actually going to the muscle, what we call the peripheral nerves, that those could be involved. And even where the nerve and the muscle communicate together, what's called the neuromuscular junction, those can have abnormalities. You can have abnormalities in the muscles themselves. We see this a lot with distal arthrogryposis, and we'll talk about that. And then there can be abnormalities with the connective tissues. Connective tissues are your muscles, your ligaments, the tendons, all those kinds of things, where they can be abnormally formed, such as in this child, these children here who have pterygii or pterygium, which is webbing of a joint. Now, when I first started in arthrogryposis, there was a lot of guilt that moms were having because they've been told for the longest time that they did something that caused the arthrogryposis. And now the feeling really is that that is really the minority of cases where that happens. And it's in the great majority of the times when that happens, it's still not something that anybody could control. But to go through a few of those, we can have a lack of intrauterine space. For example, if you have uterine abnormalities in shape, such as on the right, where this person has a bicornate uterus, or you can have massive fibroids, twin pregnancies or multiple birth pregnancies, or a lack of amniotic fluid, so they call it oligohydramnios. Now, the thing to understand about all of these is they probably would have effect on the baby much further along in development, because it takes a while for the fetus to be big enough that they do get cramped and they are unable to move around because they're cramped. And so these are usually the babies that are more mildly involved, and they loosen up much quicker. You can have infections or medical conditions that can affect the mother. Rubella and rubeola are two very serious diseases, as are mumps, for example. And these are reasons why everybody has to be up on their vaccinations when they're thinking about starting a family. Zika virus, we were all very concerned about that a few years ago. That's luckily become a little less common, but that can lead to a severe form of arthrogryposis. And then there are some maternal diseases that have an association. So mothers with multiple sclerosis or myasthenia gravis occasionally can have babies that are affected with arthrogryposis, as well as things such as diabetes mellitus. That is a pretty uncommon thing to see, though. And then what about medications and drugs? Well, all these are known to have effects on developing fetuses, and occasionally may be the underlying cause of arthrogryposis. For example, with alcohol, I've seen another number of children who've been adopted from abroad having fetal alcohol syndrome causing their mild arthrogryposis. Vascular compromise, a lack of appropriate blood circulation to the fetus. This can be a problem where if you have an abnormality of the placenta, such as something called placenta previa, or if you have identical twins who share the same placenta and there's a disproportionate amount of blood going to one baby versus the other, that can also possibly lead to arthrogryposis. And in fact, we'll talk about that again when we talk about AMYOPLASIA. But when we classify arthrogryposis, there's many different ways of doing it, which you'd expect with something so complex and so big of a group. My favorite way to do it, because it makes it a little easier to talk about, is putting into 3 big groups where each group has about the same number of children in there. The first group is the classic arthrogryposis. It's got a single condition, so they're called AMYOPLASIA. The second group has about, again, the same number of kids in it, but here there are 19 different conditions in there, and these are called the distal arthrogryposes. And these, by and large, affect mostly the hands and the feet, but they do have effects in other parts of the body. And then the third group is actually, again, about the same size as these other groups, or maybe a little smaller, but it has more than 400 different conditions in there. And included there's the Pterygium syndromes, the lethal congenital contracture syndromes, and other systems as well. But let's talk about that first group. Let's talk about AMYOPLASIA, the most common form of arthrogryposis. So it's about 1/3 to maybe even 1/2 of the kids that I see in the office. It happens to about 1 in 10,000 births. It's not inherited. It's what we call sporadic. It just kind of pops out of the blue. But you have some fairly symmetric limb positioning, meaning that the arms look very similar to each other, and the contractures and the legs as well. And you get fibrotic replacement of muscles. When I'm operating on these children and you go through what should be a muscle, it looks like muscle, except it's made out of fat. These children have normal sensations, so the nerves that give them feeling are normally working, and their intelligence is normal. And a lot of parents will actually say they're high intelligence. They have a decreased overall muscle mass, and they have this kind of a vase-like appearance to their joints, or a fusiform appearance to their limbs. They lack joint creases, like you see in the pictures here. They have that dimpling that we talked about before. And the fat has a different consistency. Even the fat that's underneath the skin has more of what I call a woody consistency. It's very firm. And they oftentimes will also have this kind of barbershop pole spiraling around their arms and legs, usually more the legs, like you see here. And we think that is caused by the umbilical cord getting wrapped around the leg during pregnancy. And most babies, if that happened, they would kick that off during somewhere in the course of pregnancy. But because the arthrogrypotic kids aren't moving very much, the umbilical cord kind of gets stuck around there and causes these indentations. And then on the left is an MRI of a fetus intrauterally, where you can see the umbilical cord wrapped around its leg. Now, for the upper extremities, the shoulders tend to be rotated inward and adducted, meaning it's held close to the body. The elbows are usually in a straight position, and the wrists are flexed, as well as the fingers are also flexed up. When we look at the lower extremities, at the legs, the hips in most cases tend to be bent up, turned to the outside, and abducted, so they're away from the body. And about 1/4 of them are dislocated. The knees can either have flexed or extended contractures. And most commonly, we see clubfoot deformities in these babies. Now, it's interesting, it's not all babies have all limbs involved. Most of them do. The most common form of AMYOPLASIA is that all 4 limbs are involved. A smaller group of them will only have the lower limbs involved. And then about 10% have only the arms involved and fairly normal legs. And about 30% of them will have some sort of a scoliosis, in many cases quite mild. Now, why do these kids look differently? Well, a lot of it has to do with timing. The interesting thing is that we start moving at about 8 weeks of pregnancy, and our head moves first, and then everything moves kind of in succession down from there. And we actually move the right side a little bit before the left side. So if you have something that causes a problem, and here we're talking actually about a vascular problem, a blood flow problem to the baby, that happens really early on, but it's a pinpoint issue, it would only affect the jaw. If it happens at about 9 weeks, again, pinpoint issue, only affect the arms. At 10 weeks, it affects some of the arms and some of the legs. And 11 weeks, only the legs. But what about if it's an ongoing issue that lasts for days or maybe even weeks? Well, then it can knock everything out. And certainly those would be the more severe kiddos in terms of involvement. What are other things we find? Well, there's a midline facial hemangioma that's known as a nevus flammus. So it's that little red mark that we oftentimes will call the arthrogryposis headlight. They can have a small jaw, again, because they're not exercising that intrauterally. In the girls, they can have decreased development of the labial folds. And in boys, they can have inguinal hernias and cryptid orchidism, which means that the testes are actually still up in the abdomen. They didn't pull all the way down. So what causes this issue? Well, the leading theory is that it's some sort of a vascular abnormality, that the blood flow to the baby is interrupted right at a very sensitive time when something called the anterior horn cell is being developed. And this comes out of findings where you have identical twins that will more oftentimes have arthrogryposis in one of the twins, particularly if there's evidence of sharing of the placenta, and in a few cases where mothers had documented hypotension or low blood pressure episodes during pregnancy. And so they thought again that there was not enough blood flow to the fetus. And so what happens? Well, from the brain on down, you have a nerve called the upper motor neuron, and that goes down to the brain and it stops at a certain level where it then connects with another nerve called the lower motor neuron. The lower motor neuron is the one that goes to the muscle. So there's a junction point within the spinal cord itself. Now, this junction point here is where the anterior horn cell is. It's actually kind of the factory for that second nerve, the peripheral nerve. So right when that is developing, if something causes it to stop developing, then you cut the communication from the brain to the muscle. And if that communication is cut, then the muscle doesn't get the information it needs to move. And because of that, you then end up with a joint contracture. I want to now move on to the second category, the distal arthrogryposis. These are by and large genetic conditions, and most of them are autosomal dominant. And that means that you just have one parent who can pass the gene on. But in many of the cases, the kiddo that we see with the distal arthrogryposis is the first one in the family to have it, that something went wrong with their genes when they were getting put together as embryos. The genetic term for these cases are reduced penetrance and variable expressivity, which is just a really nice way of saying that you can have different amounts of severity within the same family, that the child may be more or less involved than the parent that they got the gene from. And most of these affect what are called the fast twitch muscle proteins. Now, fast twitch muscles are what you have in your hands and your feet, the ones that allow you to do very fine motor skills, whereas the slow twitch muscles are your bigger muscles, like in your upper arms and legs. And what's interesting is that in many cases, the gene that's involved is one that makes a protein that is only available or only needed during pregnancy. It actually gets switched out with another protein prior to the baby being born, but by that time the damage is already done and the joints are already affected. So we look at the distal arthrogryposes, there's about 19 of them or so, but we usually refer back to this table here that has a total of 11 of these cases. And it used to be thought that there was one gene that could cause one kind of distal arthrogryposis and vice versa. Only one kind of distal arthrogryposis was related to a single gene. It was the one gene, one disease idea. What's been found, though, is it's not that. It's actually, if you see these four conditions here, all share that same gene, the MYH3 gene, or these two other ones share the PZO2 gene. So what's interesting is that you have one gene that can cause the abnormality, and yet it presents differently. And then you see there's also multiple genes that can cause the same condition. So that first one there, the classic distal arthrogryposis, actually has 4 different genes that seem to cause it. So when we look at this, there's a few things we realize is that many of these conditions probably lie on some sort of a spectrum. The other thing that we realize is just because you have a gene that has an abnormality doesn't mean that we can always predict how that abnormality is going to affect the child. And so there could be different mutations of the same gene causing different kind of conditions. But here's the classic form of distal arthrogryposis. In this case, really just the hands and the feet are involved. You have clenched, overlapping fingers with a clenched fist. The fingers are off what are called into ulnar deviation, and a thumb and palm deformity. The thumb's kind of stuck inside the palm there, which is something of a hallmark of the distal arthrogryposis. In terms of the feet, you can have a clubfoot deformity, or you can have something called a congenital vertical talus. The type 2 distal arthrogryposis, actually there's 2 of them. There's a type 2A and type 2B. Type 2A is Friedman-Sheldon syndrome, which is also known as whistling facies. They have a fair amount of face involvement. They can't open their mouths up very wide. They can have club feet or congenital vertical tali, as well as the hand deformities here. And there's another form called Sheldon-Hall syndrome. That's the type 2B. Now, what's interesting is that Friedman-Sheldon syndrome and Sheldon-Hall syndrome used to be thought to be all the same thing until it was realized that the children with Sheldon-Hall were less involved than the children with Friedman-Sheldon syndrome. And that's when they kind of divided those 2 off. So the Sheldon-Hall syndrome children have less face involvement. They have very little risk of scoliosis, but they still have the hand and foot involvement. And then for a completely different form of distal arthrogryposis is the type 10, something called Beals syndrome. And this to an orthopedist looks a lot like something different called Marfan syndrome. Children with Marfan syndrome are tall and lanky with long arms and long legs, and they tend to get scoliosis. The children with Beals syndrome look extremely similarly, except they have involvement of their hands, and it's very different genes that cause these 2 syndromes. And then there's the third category, the everything else. And you'll see there's a lot of different things that go into this. Again, there's more than 400 different gene syndromes that have been recognized to date. Now, some of these include the Pterygium syndromes. And as we said before, Pterygium is a webbing. One of the things I love to point out to my residents is that the word Pterygium has the same root as the word pterodactyl. And again, you get the idea of the webbing that a pterodactyl has. But you have these webbing or winging of the joints, abnormal thick muscles that bowstring across the joint and they limit its motion. So the picture on the left, you have a little bit of webbing behind the knees, but there's also webbing going from one thigh to the other. So this child's legs cannot be brought apart from each other very much. And then the 2 other pictures, the middle and the right picture, show that same webbing behind the knee with a very severe form of that in the middle. But there could be many different presentations. Most of these are genetic syndromes. And the pterygium can affect many different joints. They oftentimes will affect the neck, for example. And we have these abnormal soft tissues that constrain the motion of the joint. So here's another child that has the webbing of the neck there. Now, if you remember, we were talking about how the signal gets from the brain to the muscle. And one of the last steps there is the jump from the nerve to the muscle, called the neuromuscular junction. Well, part of what you need for that is something called the acetylcholine receptor. It's actually kind of the part on the muscle side that feels the signal coming from the nerve side. And if you don't have a functioning receptor there, then that communication cannot pass through. And Escobar syndrome, which is the most common form of the pterygium syndromes, is caused by an abnormality of the acetylcholine receptor. But here again, kind of like with the distal arthrogryposis, the abnormality in most cases is something that is only present during the embryologic period, and that gene gets replaced with an adult gene before the child is born. So that afterwards, the muscles can actually work well, but the problem is that in most cases, the connection has been permanently severed between the brain and the muscle. Well, what about treatment of these children? Well, certainly it's a team approach, and definitely on the top is the patients and the parents. And there's a lot of other people who should be involved in taking care of these children. And it needs to stay a team approach throughout the whole children's whole childhood and even into adulthood. A lot of different treatment options that we pull into play: physical therapy, Bracing and splinting are extremely important, serial casting for some of the deformities. And then we get to the surgical things such as loosening up the soft tissues or maybe even correcting bony deformities. Now, what is the goal of treatment? Well, there's two goals. One for me is independent ambulation, but we always have to keep in mind that walking isn't the most important thing. And oftentimes using the arms is more important. And in fact, when we look at outcome studies, what we find is the main thing that limits somebody from being independent has less to do with their ability to walk and more has to do with their ability to use their arms. So a few important facts. These children are usually quite intelligent. They are sensitive to pain. And you can't restore an abnormally developed joint. You can try to make the joint work better, but we can't make it into a normal joint. And there's certainly a variable spectrum of arthrogryposis. It helps to have an accurate diagnosis so we can try not to miss other things that can go along with the condition. But a diagnosis is not always easy to make, and it can be very expensive. And sometimes it doesn't really change what we're going to do for the child. Sometimes it's just a matter of treating what you see. Children are also very smart in these conditions. They learn how to compensate. So on the one hand, we want to be careful not to upset a functioning adaptation. But on the other hand, we also have to realize that oftentimes these children can learn to readapt. And one of the most important ways for me to think of this is when I first got started, I met a lot of children that would use two hands to write with. And everybody said, oh, hey, they've learned how to write, leave them alone. If you do anything, you can really mess them up. But what we started to find is actually if you put one wrist in a better position, well, now they could write with one hand, that they still learned how to do it. Now, from here on out, a lot of this is my opinions. And a lot of that changes with experience and learning. And one of my favorite quotes from Will Rogers is, good judgment comes from experience, and a lot of that comes from bad judgment. And there's no textbook or cookbook answers to the things we do here. We keep on trying to develop protocols and algorithms, but a lot of the treatment needs to be individualized. And certainly we're still all trying to work through this. And that's why it's so important for all of we surgeons who deal with kids with arthrogryposis to work together in order to keep on coming up with better ideas on how to do things. But my protocol is I treat the feet pretty much as a newborn or as early as I get the child. I wait until the child is at least 12 to 18 months before I treat the hips. And I wait until they're about 4 years old before I treat the knees. So let's start talking about the feet. So the feet kind of come in two basic flavors, the club foot and the congenital vertical talus. So talking about the club foot first, what we want to do with the club foot is make it into a braceable foot that is fairly flat or plantar grade, so they have something stable to stand on. We want to get there with the least amount of surgery and cut down our chances of recurrence as much as possible. Treatment recently has become much less surgical. We still get relapses, and relapses are going to happen regardless of treatment. But the important thing to realize is if there's a lot of surgery involved with treatment, then the relapses become harder and harder to treat afterwards. So most of us have gone towards Ponseti casting for these children. The Ponseti casting is basically weekly casting, and at some point in time doing the Achilles tenotomy, a little nick through the skin to loosen up the Achilles tendon, and then long-term bracing. The Achilles tenotomy in the young kids under a year and a half or so, or as I like to joke, young enough that they can't remember my face, I will do as an office procedure. We put a little numbing medicine on the back of their ankle and then inject some local anesthesia and then just make a little nick through the skin to get the foot to come on up. We've made a few changes to how the actual Ponseti technique is done for children with regular club feet. In cases of severe ankle contractures, we may start off with doing the Achilles tenotomy as first thing, or maybe early on in the treatment and keep casting after that. We still do the serial casting. Weekly is what Ponseti always talked about, but even he would sometimes do casting more often in the week, and very often I will do it twice a week. Still do the percutaneous Achilles tenotomy, and then it's a lot of bracing, but the bracing is a little bit different. So here, a quick talk about the Achilles tenotomy. On the left there, you see this child with a pretty severe club foot there, very tight ankle. So we've numbed up the foot with the numbing medicine. Now we're injecting our local anesthetic. And here we are, sorry, it's a gross picture, but we're nicking the Achilles tendon. And then we are stretching out that ankle and putting on our first cast. You can see how much correction we got just from that first little nick of the Achilles tendon. The important thing to realize is I'm not trying to make the foot come up at this point in time. all I'm trying to do is get the foot to roll out to the outside, because that's the most important thing that we're doing with the Ponseti technique. But the whole idea is to make feet that look like these turn into feet that look like that. Now, what about bracing? Well, in the typical club foot, we use what's called a foot abduction brace, like you see down here on the bottom left. And these have been really helpful. But the thing is that they require the baby to be kicking. And that's how when they kick with one leg, they're stretching out the other side. Kids with arthrogryposis don't kick. And so they will very quickly get a recurrence with these braces. Also, if they have hip or knee contractures, it's tough to fit these braces on them, such as in these two children here. It's really difficult to make those braces fit. So instead, I'll use what we call a dual purpose AFO. So during the daytime, it functions pretty much like a solid AFO, like you see here, where we mold it to kind of correct the foot out. And at nighttime, we have these pull straps to stretch the foot out. So some examples here. This young boy at 3 years of age, he had, sorry, I'm trying to get my little pointer pen to work here. He had already been walking on these feet. He had never had any treatment, but he'd been walking. That's what these big calluses are. You can see where he was actually putting weight on these feet. And that's what the feet look like. So our treatment with him, we did that initial Achilles tenotomy. We did another 9 casts after that. And this is what he ended up with. It took us about 3 months altogether to get to this point. Now, in all fairness, he's had a number of relapses, but nothing to the point of where he started off. We've been able to keep him up walking with doing nothing else than casting him from time to time. Here's a much older boy. He was 10 or 12 when he was first adopted by his parents from China. He'd already had some surgery. You can kind of see the scar right over here, but you can see a very severe relapse on both sides of that scar. So it took a fair amount more time with him, but we were able to get him casted out. And then after we corrected his knees, we got him up walking for the first time in his life. And now he's a community ambulator with his crutches, a very active young man. What about relapses? These happen very commonly. And nowadays I've gotten comfortable telling parents that it's very likely, parents of new children that I meet, it's very likely that they're going to have a relapse and we'll have to do more than one series of casts on the child. What I tend to find is that as the child gets older, there's more and more time between casting series. And then there's a certain point in time where the foot just kind of gels out. It kind of holds its position. And in some children, it's as young as 6 years of age. Other kids, it could be 12 years of age. It's very variable. And I don't know why it is that variable, but we do get the feet and then finally settle out. So this child, 2 years after casting, had another relapse, and that's kind of what they look like. But again, foot looks in a much better position. This is a very typical place to get a big corn to develop there because we're putting a lot of pressure on that side of the foot when they start getting their relapses. What we want to avoid is this. This is a child who came to me when he's 15 years old, had multiple procedures, and it's hard for me to recognize what bones are left, what bones have been fused together, and what they have taken out, because a lot of that was done. And the only way I could fix this foot was actually putting an external fixator on him and making a bunch of cuts to the bone to straighten them out. Now, there's a variant of the club foot that we call the Equino Cavus club foot. It happens, we see it maybe 1 in 5 or 1 in 6 kiddos who we treat for club feet. And it's a bit different from the club foot. It is not rolled in as much, but it has a very high arch that goes across the whole foot, such as we see over in this picture here. You see this high arch that comes all the way to the outer border of the foot. And the trick with this is it takes a little bit of a different casting method than what we do with the regular club feet. You need to recognize that, or the surgeon needs to recognize that, or else they can end up with an over-treated foot that really doesn't look very good. And of course, after we correct it out, we want to cast it. Very often, though, these children will have these ongoing toe contractures that are an issue as long as the child is growing. Then finally, we can do something to stop them from bending over again. But so it takes a little bit of a different casting method. What we're trying to do is actually just straighten the foot up, bring the front of the foot up compared to the middle of the foot, and stretch it out that way. But so we can take feet that look like these. You can see here's that deep crease that goes across the bottom of the foot and that high arch that we talk about, and turn to a foot that looks like this. We're in the middle of casting here, and here after we've done our Achilles tenotomy. And what about that other foot deformity, the congenital vertical talus? This is essentially the anti-club foot. It's the only thing it has in common is the fact that the Achilles tendon is tight, but everything else is the exact opposite. The heel rolls to the outside. The front of the foot is swung to the outside. And the treatment of this used to be a very intensive surgical treatment, just like it was for the club feet. And then Matt Dobbs came up with this great technique now, well, gosh, almost 2 decades ago, of casting these feet out. He was somebody who did his residency with Ponseti and thought, well, if you can treat the club foot with casting, why not the congenital vertical talus? So it came up with a very nice way of being able to do that, where we gradually stretch the foot out and roll to the inside, and then line the middle of the foot up with the front of the foot. Now, very often we still have to do a little operation here to line 2 bones up with each other and then put a pin across that at the same time as we nick the Achilles tendon there to get the foot to come up. And then again, it's casting and bracing after that. But then you have a foot that looks like this and turn into a foot that looks like that. And there is the entire surgical incision. Whereas in the past, when I first started in practice, was an incision that started here, came all the way around the back of the foot, and again around to the outside of the foot. So then that's the foot. Then we get onto the hip. And like I said, the earliest I'll look to treat the hip is at about 1 year to 1.5 years. And the hip comes in 2 varieties. It's either the hips with contractures or the hips that are dislocated. So let's start with the contractures first. The typical contracture, the hip is flexed up, it's turned outwards like you see over here, and it's also moved away from the midline of the body, abducted. So if you only have a flexion contracture of the hip, we've come up with this nice little thing called a percutaneous Achilles tenotomy, where you see this is as far as I could straighten up this child's hip, made a little incision. There's the incision right there, made a little incision there to loosen up some of the scar tissue in the front of the hip. And that very often will allow you to get enough stretch so you improve the hip contracture significantly. But the typical hip contracture, though, is that flexion, abduction, external rotation. And those are very difficult to treat up until we came up with the idea of saying, well, you know, it's not a matter of getting the ball in the socket to rotate to where we want to be. Let's just leave the ball where it wants to be in the socket, and we'll move the rest of the leg around to where we want it to be, something we call a reorientational osteotomy. So you take this child here. This is what she looked like when she was born, her legs out to the side like that. And this is what her x-ray looked like with her just lying down. So what you do is you make a cut in the top of the thigh bone about this level here. So we leave the ball in the socket where it wants to be, and we take the shaft and bring it down to where we want to be. So that's what we see right there. This is where we cut the bone. You see that cut right there, and bring the shaft down so the knee lines up with the body. And what's interesting is you make such a significant deformity here, a good 90-degree deformity, but the bone reshapes itself over time in the new position. So here we're starting to see those little bumps that you have on the side of your hips starting to come out by the time that we took the child's hardware out. And here she is as a 10-year-old. And this looks a little bit of a strange hip, but not that far off from what would be thought to be a typical hip. What's more important is what she's doing. This is her hip motion down here. Can flex one hip all the way up and the other one all the way down. And here she is up and walking. What about the dislocated hip? Well, the traditional thinking was if one hip was out, it made sense to put it back in. But if both hips were out, you should probably leave them out because people were worried about the hips becoming stiff. But what we found was that the hips already have a certain stiffness to them before you put the hip in. And our studies have actually found that that stiffness only slightly worsens after you put the hip back in, and not to a degree that's going to cause any difference in how the child can get up and get around. There's other studies that show that arthrogrypotic adults, if you put their hips back in joint, they will actually walk better than if you leave their hips out of joint. So I'm a big fan of putting the hips back in joint. And we have a lot of people who come to us saying, well, my doctor didn't want to do it because they thought there were no sockets. Well, the good news for those doctors is there always is a socket to put that hip back into. So here we have little Emily. She had her club feet. We fixed those up. She had a dislocated hips. We put the balls back in socket. And then since that time, her family sends me pictures every now and then to let me see how well she's doing. And she goes on hikes with her family. So now let's move over and talk about the knees. So the knees, again, I look to get to those that are about 4 years of age. And the deformities are either the extended knee or the bent knee. So why do we treat the knees? Well, certainly if it's a straight knee, those children have an easier time learning how to walk. But when they get to be 5 or 6 or so, having a straight knee becomes an issue when you're sitting in a car or an airplane and your feet get in the way. And the kids with the bent knees, depending upon how bent they are, they can really cause issues with walking. So again, here we got, that's what a straight knee looks like. And so we want to make it easier for her to be able to sit in the future. Here's a really straight knee. This is a hyperextended knee. This is actually the back of the knee. There's the front of the knee. So this knee is so extended that we actually call that a dislocated knee. And the typical treatment for these is casting until we can slowly stretch out the knee, and sometimes having to do some surgery in the front of the knee as a baby or a young child so we get the knee to bend better. And then it is bracing, bracing, bracing. Very important to realize that the children who have these extended knees, they oftentimes will also have an outward contraction of their hips, that their knees are actually pointing out to the side. And why that's important is because they also oftentimes will have club feet that need to be casted. And if people don't recognize that this is not the front of the knee, but the front of the knee is over there, then when they cast, they will actually be bending the knee the wrong way. You end up with this very awful knock-kneed deformity with a lot of looseness of the ligaments. And this is actually the way that the knee needs to bend, is with that smiley face pointing straight forward. But what can we do for these children whose knees don't bend? Well, we can do an extensive operation where we make one long incision, or I like to do several incisions on the side and one also on the inner side of the knee. So we can lift the whole quadriceps muscle off of the thigh bone and then shorten the thigh bone down a little bit. We think of this as a short muscle with a long bone condition. So we first try to lengthen the muscle, and if that doesn't do the trick, then we shorten the bone until we're able to get the knee to bend well enough. I still find this to be one of the more challenging procedures, not so much in doing the procedure, but in the rehab afterwards, because it's very uncomfortable for the children. So I really want to make sure that everybody is on board, that they'll realize it's going to take a lot of therapy when we get around to that after the operation. What about knee flexion contractures? Well, if you have a flexed knee, it makes walking more difficult. And since more than half of the children with arthrogryposis are going to become adults who are walking the community, we really want to make them walk as efficiently as possible. And if you have a very severe knee flexion contracture, such as this child here of a 90-degree flexion contracture, it actually causes difficulties with sitting. So there's different things we can do. We can try casting or using stretching braces. I tried those early on in my career. I did not have much luck either getting the knee straight, or if I did get them so much straighter, maintaining that. They would oftentimes would come back. I've had colleagues who tell me from time to time they've had good luck with it, but that hasn't been my experience. So then we can go for the mild ones. We could do some soft tissue releases, trying to loosen up things behind the knee. We can do what's called an anterior hemiepiphysiodesis, which we'll talk about in a second. And for the severe contractures, we can actually do a cut at the bottom of the thigh bone to straighten out the knee, or we can use what's called a Lizaroff to straighten out the knee. So this is what's called a hemiepiphysiodesis. And what that means is that we're tethering the front. This is the growth plate of the bottom of the thigh bone. We're going to tether that front of the growth plate, slow it down from growing so the back part can keep on growing. And as it does that, it slowly straightens it out. So if this is the thigh bone and this is the shin bone and here's the kneecap and here's that growth plate. And if we slow the growth plate from growing in front, but let it keep growing in back, we'll get this to slowly happen where we fake a straight knee. And this works well for contractures less than 40 degrees. And I've been slowly working my way up to contractures less than 50 degrees to get that to work. But if you take a look, so here we've just put these plates in place, and here we come back several months later. And if you look at the angle of the growth plate, you're seeing it starting to angle more over time. And on top of that, those screws are starting to splay out from each other more and more as we tether the front of the growth plate and get the back to keep growing. So after 2 years here, we got this knee just about fully straight, but you can see how that growth plate is really at an angle there. Now, what's the problem with that is this growth plate is going to want to what's called remodel itself. It wants that growth plate to be, again, square to the shaft of the bone. So over time, this undoes itself. And that's why we want to keep on bracing these children even after we've taken these little plates out, so that when this growth plate, we got it straightened out like that, when the growth plate wants to go back to a normal position, instead of this happening and the contracture coming back again, this happens where everything behind the knee stretches out. So that's why the bracing is so important. This is what I've gone to lately. It's a little bit of a different design. I think it gets our correction quicker. And it's also a little less low profile, or a little lower profile on the knee and therefore seems to cause less irritation. Now, what about the more severe contractures, those that are greater than 50 or so degrees? What can we do about those? Well, one of the things we can do is a re-angling of the bottom of the thigh bone, make a cut in the bottom of the thigh bone and acutely. So kind of like we do the growth plates, only we do it right there in the operating room, cut the bone here and bring them up. So we fake that straight knee. The difficulty with that, so this is what that would look like. And that works quite well. So this child here, actually, he's a teenager, never did walking, but we were able to get him straightened out and straighten his feet out, and we're able to get him up. And this is what he looked like. And that's how that procedure is done. But we need to do it when they're almost done growing, because if not, that remodeling thing we were talking about at the bottom of the thigh bone is going to undo our work. Here's a child that was sent to me. They had a straightening procedure, an extension osteotomy done before they were a year of age. So this is what they look like after the procedure. But look what happens only a year and a half later. They've completely remodeled the femur and their contracture has completely come back again. So for the younger kids, what I like to do is use an external fixator. And what I'll do is make an incision on both sides of the knee, on the outer side of the knee and the inner side of the knee, to get behind the knee and loosen up the muscles and the capsule of the joint back there, and then gradually stretch out the knee. So here we have a young man. We corrected out his feet and then we corrected out his hips so he could sit well. And here he is actually upstanding in his braces. So he was able to walk in KAFOs, even though he had these severe contractures. But then we put this external fixator on. And he actually did really well. I always make the joke that I don't know if this was Halloween or if he was really angry to see me, but his knees both came out nicely. And here he is walking with short braces when we first got around to it. Now he's much, much older now. So it's very cute seeing these pictures of him. But that's how we did that. All right, so let's move on now to our final topic of the session, talking a little bit about scoliosis. So scoliosis and arthrogryposis can happen at any age. And in fact, kids can be born with curves that they develop during pregnancy. And we call these prenatal curves. And the shape of the curve actually reflects the position the baby was in the uterus, because they were not moving. They always kept that same kind of curve position, and it just kind of took. We can also talk about curves that happen early on between birth and about 3 years of age. We call these infantile curves. And these tend to be the children who have a very low tone form of arthrogryposis, or some people will call them like floppy babies, where when you sit up, they just kind of collapse, and that ends up going to a curve. There are things called juvenile curves that happen between the infantile age and puberty. These are not the most common age to have the curves develop, but then in adolescence, we get another spate of curves that happen, and that more mirrors typical children where they get curves at about the adolescent time. So here's a prenatal curve, this little child at 2 months of age. You see at 14 months still has that curve. Here he's up when he was able to get up on his knees. So there is a 4 years of age, 8 years of age, 8 years of age, and his curve is always pretty steady during that period of time. So we actually got to the point that we stopped bracing him, and then he had adolescence and the curve started to take off. And we ended up having to do surgery for him. But what can we do for these curves? Well, the best thing we can really do is try to do physical therapy to strengthen up their back, especially if we can do asymmetric exercises where we strengthen up the muscles that can help pull the back over. We can do sensory integration where we're trying to teach them to feel more where their body is in space. So they're using their own muscles to try to balance themselves. And we could try to, especially little babies, try to do a lot of tummy time, a lot of prone exercises. So they're trying to pull their head off the ground. And by doing that, they're using a lot of their back muscles. We can, in the more severe cases, in the young kiddos, we can do spine casting, or in the older kiddos, we can go to bracing. And then we end up having to do, in some of these kiddos, surgery. So let's talk about all of that for a little bit. So this is what spine casting looks like. Here's a 2.5-year-old boy with a 40-degree scoliosis, which is a pretty big curve at that young age. And here he is in a cast. So we go to the operating room. We actually put a cast on them. And here he's at 4 years of age. After 5 casts, we got the curve down to about 22 degrees. And we were able to get him out of a brace for a period of time until it slowly came back. Now, the difficulty about spine casting is that the cast is on, it can't come off until we take it off. So it's actually on for a number of months. And we have to go to the operating room to do it. We want to have the child asleep and comfortable. And we actually put them in traction to kind of stretch them out as we're putting the cast on and then molding it to try to straighten out the back as best as possible. This is what braces look like. So the brace, we're trying to support the back, trying to push things into a good alignment. Now, the difference between casting and bracing is that casting has a chance at actually making the curve smaller. Although in arthrogryposis, we have much less luck in trying to make the curve go away altogether as we do in other conditions. But the thing about bracing is bracing does not make a curve smaller. The best it can do is slow a curve from getting bigger. So that's why if we have a very young child, we're going to try to do everything we can to cast them first before we go to bracing. And then we get to the age where the curve is big enough that we have to do something more. We can't do something from the outside anymore, so we go to the inside and we start implanting things. And there's now a few different kinds of expandable implants. What we used to have to do is actually go to the operating room every few months and kind of stretch out the implant to keep up with growth. But now we have these implants that we can actually adjust from the outside. So here's a 5-year-old. We did 2 years of spine casting, then went to the operating room and put in this expandable implant. And here you can see we're about 2.5 years after implantation. And if you look there, you see this yellow area here. This is where the implant has been expanded over time. And so it's been keeping up with his growth. And what we have is electric magnet we can put on the outside of their body that spins a little magnet inside the rod, and that's what helps expand them up. For the older children, we go to what's called a formal fusion. So here's a 16-year-old girl with a 96-degree curve and what's called pelvic obliquity. You see, here's one part of her pelvis, here's the other part. So it's really at an angle there, making it very hard for her to sit. She's always sitting on one tush. So the whole idea is to straighten her out, take our fusion all the way down to the pelvis so we can make the pelvis flat. So when she's in her wheelchair, she can sit comfortably. What we do with this is we push all the muscles off the bones. We put screws at every level there, as you're seeing here, and then put a rod down either side of the spine. So the rod helps hold the spine in position. And then you scrape up the vertebrae. So the vertebrae think they've been injured. And what they try to do then is heal themselves together. And in doing that, they heal one vertebrae to the next, and you end up with a solid backbone. And that solid backbone then won't bend over time. You could actually take out the hardware if you wanted to, but it's a big operation to do so. So we really don't do it. Well, that's my talk. I want to thank everybody for attending, and I'm here to take as many questions as I can, and we'll go from there.
Thank you, Dr. Van Bosse. We appreciate your presentation so much, and there was a number of comments and a number of questions that came in, both from Facebook and our Zoom Live. So I will start with one question from Facebook. Do you recommend surgery or only OT for thumb and palm?
Well, certainly starting off with as much therapy as possible. And if therapy can't take care of it, then it's important to move on to doing something surgical because you want that palm in a good position for pinching. If the thumb is all the way stuck inside here, they can't really use their thumb. And so what the hand surgeons that I work with, and actually there's a lot of really good hand surgeons out there who understand arthrogryposis now, they'll want to get that thumb out so that you have an ability to pinch.
Great question. So a question from Zoom, should adults with arthrogryposis continue to see a specialist? I
think they certainly should, and maybe not on a very frequent basis, maybe once every year or 2 or 3 years. The specialist they should see, though, should be a physiatrist or rehab doctor. I kind of slight my adult colleagues, but I really think that adult orthopedists are not interested in somebody who's got an ongoing condition, especially if it may not lead to surgery. You'll find some that have that interest, but usually the mindset of doing surgery and then moving on with that patient. So when you have somebody who's got an ongoing condition such as arthrogryposis or cerebral palsy or all these other things that pediatric orthopedists are very involved with, when they hit adulthood, they really should go see a physiatrist. If the physiatrist finds something that needs surgery, they can refer them on to a surgeon. But the physiatrist can take care of the the bracing. They can help out with social needs, all those other kinds of things that an orthopedist doesn't do as much or doesn't do as well.
Wonderful. How do you measure the degree of the knee contracture?
Ah,
Do you have your tools with you?
I do. If I can get one. Here we go. So this is called a goniometer. And what we actually do is we just put that on the joint to say, okay, how far is that joint bent? So you put one arm on one side and one arm on the other side. So with a knee, this would be a straight knee. This would be a knee at 45-degree flexion contracture, if that's as far as you can straighten it out. This is a knee at 90 degrees contracture, as far as you can straighten it out, or vice versa. If the knee goes all the way straight, but it can bend, it only bends this far, we say it can only bend to 20 degrees.
I love that tool. We've used that a lot in your office. All right. Is it possible to have some of AMYOPLASIA and distal?
I suppose academically you could come up with a way that would work, but not really. It's one or the other. Now, can it be difficult trying to figure out between the two? Yeah, I've had it plenty of times where I thought for a few years, oh, that child's got AMYOPLASIA, and then I'll think, well, actually, the rest of the big joints aren't as involved. Maybe it could be a distal arthrogryposis. So I'm always very happy to tell everybody I'm not a very good diagnostician. But I do think that genetics are becoming easier to get. They're getting cheaper, and hopefully we'll be able to get everybody tested in a more straightforward fashion. So it just takes some of the guesswork out of it, or some of the concern out of it. I also think there's 3 reasons to get a diagnosis. One is to make sure there's nothing else that we need to know about the child. But that's really kind of the minority of times that happens. The second reason is that if parents are thinking about expanding their family and they want to know what's their chance of having another child with arthrogryposis. And the third reason is for when the child themselves grows up and they want to have a family, what's the chance of them having a child with arthrogryposis? But I think just on top of that, there's also just a lot of times that people want to understand what's going on, even if it's not going to really change the future any.
Great. Still on the topic of genetics, we have, I assume, a mom who is just got back from genetic testing with their little man, and he has the GLE1 mutation. Is this something common that you see in your practice?
GOE1.
GLE1 mutation?
So it's not one of the ones that springs right to mind. But again, when there's 400 different mutations, there's a lot of them out there.
Right. Absolutely. All right. So you touched on the Zika virus a little bit earlier today. What is the viral theory at this point? Mosquito-borne?
Oh, yeah. Oh, it's definitely mosquito-borne.
Okay.
Yeah. And there's, it's only one particular kind of mosquito that does it. I can't remember exactly which one that is. But yeah, it's very much a mosquito-borne illness.
Okay. So we have a family coming to see you in September, and they would like to know if there are any specific therapies that they should work on with their therapist to better benefit and prepare them for the visit with you.
It's a little bit of a broad question without knowing the child in particular, how old the child is, what the child's able to do. But if the child is not yet walking, then definitely still just trying to do as much as you can to get the child in an upright position so they feel what gravity is like across their body. Stretching is always really, really important. It's one of the things that unfortunately kind of drops off over time, especially if you have a child who's up and walking, that it's a little hard to keep up with the stretching, but again, very important to keep doing that. Pool therapy, I think, is great. And then you can always go for the other things if the child is old enough and they have accessibility to it. Going for hippotherapy or horseback riding therapy is a great thing to be able to do.
Excellent. All right. So for those of our AMCers who do not know their type of arthrogryposis, what can they do to find out?
Well, the first thing would be to visit a geneticist. Now, one of the problems is that not all geneticists are created equally. So not all geneticists are interested in arthrogryposis. So you need to kind of look for one that has an interest in it. But then they can start off with, looking at the child, trying to understand what the child looks like and what possible arthrogryposis they may have. Sometimes it's very obvious and they can limit the amount of testing they have to do. Sometimes it's more intricate. There are a number of panels, genetic panels, so that you take one sample of blood and you check it for 80 some different genes that are closely associated with arthrogryposis. That works when you're looking for the more common type things. But when you're looking for the less common things, you can miss something. And that's when you go for something called a whole exome sequencing, or nowadays, actually, we're more for the whole genome sequencing. The whole genome sequencing looks at every bit of DNA and maps it all out to understand it better. And by the way, it's the great thing about doing this on Zoom is that I could actually sneak into an article and look up GLE1, and yet it exists. It's a very uncommon one. And it's the only thing I tell you, it has to be for an article we just submitted for publication. It has to do with arthrogryposis and with related scoliosis. So the only thing I can tell that family is to keep a close eye out for scoliosis.
All right. Awesome. Another great question came in. How can we help educate our local treatment centers and hospitals to learn more about arthrogryposis as it is so rare? Many nurses and doctors are not sure how to treat it.
Well, I think they're at the right place because I think AMCSI has done a lot of work in trying to broadcast awareness about arthrogryposis. There's a lot of articles and pamphlets that are out there. AMCSI has a wonderful neonatal intensive care unit brochure that we're trying to get distributed as much as possible. So there is material that's out there. And there's a lot of good review articles that are out there also to try to give things in kind of a bite-sized form that everybody can read and understand. But the good thing is that the family already is saying that they want to be the advocates out there. And that's what they need to do. They need to get out there and explain what arthrogryposis is and get people interested in understanding it. And also stay in touch with other people on social media, because I think that's one of the big things. So many of the families that I have met have said, you know what, our local doctor was saying there's nothing we can do, or we have to do this really radical thing. But I talked to other people online that said, no, we did this, or our doctor suggested that, and therefore we wanted a second opinion to find out more. And I think that's very important. And what I then try to do is try to rope that local doctor in so that we try to make them part of the care team. Not that you abandon that doctor, but you try to keep them involved so that they can learn from the patient that they already have an established relationship.
Wonderful. All right, here's a good question. If a mother caused the AMC, how common is it to have it happen again for future children?
One more time, if a mother caused it?
Yeah.
Okay. And again, I think that's a tough way to put it, because you can say it's maternally related issues, but saying that the mother caused it, it almost makes it sound like somebody meant to do that. But with maternally related issues, it all depends what it is. So we can go into the really uncommon kinds of things where, for example, mothers can have antibodies against a developing fetus. Well, these things happen. They happen 1 in a million times, but if you're that family, you might have a child with that. But in most cases, so if we're talking about AMYOPLASIA, again, the most common form of arthrogryposis, and again, it is a non-genetic form, it is still very uncommon for a family to have more than one child with AMYOPLASIA. So I'd say that in those mother-caused types of arthrogryposis, extremely rare to have more than one child with it.
Great. What options are available for upper extremities in adults?
All depends upon what the issue is. So a lot of the same surgeries that are done for the children could still be applicable in adults. One of the very common ones, actually, one of the ones that I did in New York before I came up here that I was so excited about, was a woman who had a form of distal arthrogryposis and had the typical very flexed wrist. And all I did was straighten out her wrist, And it was wonderful because she then sent me a photograph a few months later of a wedding ring on her wrist. And so I got to tell everybody that my surgery allowed her to get married. Had nothing to do with it, but all the same, there are a lot of things that can still be done depending upon the deformity that the person has and the ability they have to use their hand. There are a lot of things that can be done. So it's really a matter of having a consultation with a hand surgeon who understands arthrogryposis.
Great. What is the psychological effect on kids who go through surgeries and constant bracing and casting? Is there counseling that you recommend during treatment?
Not so much counseling. And there's the occasional child who probably could benefit from that. The other thing that we see that it just I find so extremely remarkable is how resilient a lot of these kids are, and that how resilient the parents are also. Just so many parents that I have of able-bodied children where you're like, oh, we have to do surgery on this, and the family just implodes. It's terrible. Whereas you say to an orthogrypotic family, well, we need to do surgery on the hips when they're 2. We'll do surgery on the knees when they're 4. Oh, and when are you going to do the hands? They're like, okay, we'll count them all up. We'll get ready for it. And the same with the kids. We just recently had a child from Mexico that we very severe club feet, and we're casting him out before we go to surgery. And I would say for the first 4 or 5 casts, you could hear him 2 or 3 stories up in our hospital. But then we got to one day where he made a little bit of a fuss. We started the casting, and then he became a chatterbox. And it's, doctor, what do you think of this? Doctor, what do you think about it? And you saw that he just completely relaxed. Even though we were doing the casting, and say, oh, that hurts a little bit, doctor, be careful. And then go right on to being his happy little self. I think the big thing that makes a difference is how much the parents are able to provide strength for the child and resiliency. And mind you, this is a tough thing for the parents also. And I know a number of parents who themselves have gone on to have counseling so that they can feel better about doing this to their child, because oftentimes they feel like, I am doing this to my child. Yeah, but you're also helping your child. And so that's oftentimes they need to feel better about themselves and what they're doing for their child in order to give their child that support that the child needs.
All right, a few more questions. Could muscle strength, grip in your hands deteriorate or weaken over time?
Well, it certainly can. If we're talking about over time as an adult, that certainly can. That's called atrophy. And we all experience that. The less you use a muscle, the weaker it becomes. So it's very important for arthrogrypotic people of all ages to stay active, to keep on using those muscles, keep them strong. We know several adults with arthrogryposis who go to the gym, which I think is just fantastic. That's what they need to keep doing. Now, if you have a child who's getting weaker over time and they're getting weaker in their hands, that's somebody who needs to go see a neurologist to make sure there's not something else going on that could be causing an issue, an underlying syndrome that could be weakening their muscles and nerves.
What kind of treatment would you recommend for an adult who underwent very little treatment as a child?
That's another one of those wonderfully broad questions, so hard to say. It also is a matter of what their goals are. So you need to weigh 2 things. What are the goals of the person, and what is the person's potential? So we certainly, I look at every baby I see as having the potential to walk, and then over time you start finding there are those that they may not have that potential, and we just try to get them as high as they can and what they can do. There are also, certain adults that at 40, they suddenly say, geez, I've been in a wheelchair for a long time. I wish I could get up and stand. Well, let's take a look at you. Do you have bad hip and knee contractures or foot contractures that we can straighten out? Maybe that might help you stand. But otherwise, are there other things that are getting in the way of this that might be weakness related or balance related, for example? And is it really something then that the person wants to go through?
Great. We have a lot of Zoomers on Facebook that just want to say hello to you. And I just thank you for all that you do, especially for this presentation. What is the possibility of a future presentation covering upper body, specifically hands and elbows?
Well, I think we're going to talk about that in a few minutes, so I'm going to have to hold my mouth on that one. And there are certainly much more experienced people who can give a much better talk on those types of things. But what I do want to say also is I really appreciate everybody who's waving out to me and all the good thoughts. But it's really important to realize I am just one of several orthopedic surgeons who likes to do work on people with arthrogryposis because they find it so rewarding. So I see myself more as a representative of all those people.
Wonderful. Okay, and last question. How do we get an appointment with you for a second opinion?
So people who know me know that I also had a wonderful nurse who used to work for me, Debbie, who just retired a couple of months ago. We're going through a little bit of a changeover, but now the new person, Pam, who is also equally wonderful, and I think she's going to become a much loved person on my team pretty soon as well. She is gradually assuming the role. Another nurse by the name of Kim has been helping her a lot, who's also a great person. But it's really a matter of reaching out to them. I think my wait list, COVID has done really strange things to everybody's practice and similarly to mine. So I'm not sure what my wait list is for new patients at this point in time, but my census has gotten so much shorter. So hopefully it would not be too long of a wait.
Wonderful. Thank you so much for taking your time to do the Q&A with us as well. Those are great questions, everyone.
Well, this was very fun.
And there's your contact information. Wonderful. All righty.
Well, Ani, I think it might be time to allow our special friend to make a special announcement. What do you say?
Sounds good to me.
All right. So I'm going to move forward, and Dr. Bambosa?
Well, so here's the exciting thing is I am just the appetizer. I'm the kickoff because in a couple of weeks between July 18th and the 24th from 7 to 9 p.m. the evening, we are having our virtual annual meeting. So everybody feels terrible about the fact that we don't have an in-person meeting. And I can tell you there are more than a few tears, both last year and this year, when we came to the realization that we could not do this in person. But this is what we're doing instead. So we're making the best of the situation. We've lined up a good evening of activities every night. And there's going to be more information to come on the website, as you see down there, the link down there. And that gets back to that question where somebody said, hey, what about an upper extremity talk? There's one of those in this mix.
Yes, we are very excited for our virtual conference. So we hope you guys will check out the website. You will register. It is free to attend. We're excited to kick that off, and we can't wait to see you guys then. All right. So the recording of today's talk will be posted on our website, and I think Facebook might even save it for us. But don't forget to join us for our virtual conference. In just a second, Jean is going to allow everyone to say hello. So please turn your webcams on, and we're going to take a picture, group photo time.
That's right.
Quite
So,
as fun, but
all right, ladies and gentlemen. So you should be able to turn your cameras on. If you can't, raise your hand and I will help make sure that you have that ability. So there's a button inside of Zoom that will allow you to raise your hand. And oh, look at these faces. So for our Zoom newbies, remember in the upper corner, you can turn on a gallery view so that you can see more people. And I just want to make sure that everybody who wants to can get it on. And I'm seeing some hands pop up. So allow me to click you a few buttons here to allow you to start your video. I will click over here and ask you to turn it on, and then that should solve the problem, hopefully. All righty, so Ani, I'm gonna click some things over here, and I'm gonna tell everybody to give me, once I click some magical buttons over here in the internet world, I want big, happy AMC smiles while we take a group selfie. Are we ready? We're gonna do a delay. 1, to AMC. Awesome, awesome, awesome. Thank you all. All right, we'll page forward one more. I'm going to do a couple more because there's so many people on video, I can't fit you all in one screenshot. So I'm going to do one more. Ready? AMC cheese. And there we go. Oh, awesome, awesome, awesome.
You all look great in your blue. Thank you so much for participating in AMC Awareness Day and our special event, AMC 101 with Dr. Bosse. We appreciate each and every one of you, and we will see you in a few weeks. Make sure you check our social media and our website for all the information. Thank you, everyone. Good night.
Good night. Thanks, everybody.